Welcome to Emergency Insights. I'm your host, Dr. James Carter. Today we're addressing a dangerous and often misunderstood condition, heat stroke. With global temperatures rising, recognition and management of heat stroke is more critical than ever. Joining us is Dr. Emily Zhu, an expert in emergency and critical care. Emily, thanks for being here. Let's begin with the basics. What exactly is heat stroke?
Heat stroke is the most severe form of heat-related illness. It's defined by a core body temperature usually exceeding 40.5 degrees Celsius, central nervous system dysfunction like confusion or coma, and often multi-organ failure. It's a medical emergency.
How is heat stroke classified clinically?
We divide it into two main types. Classic heat stroke, which results from passive environmental exposure, like being in a hot room without air conditioning, and exertional heat stroke, which happens during intense physical activity.
Who are the most vulnerable to classic heat stroke?
Primarily the elderly, people with chronic illnesses, or those who are socially or physically unable to escape the heat, such as during urban heat waves. Children, especially prepubertal ones, are also high risk due to their underdeveloped thermoregulatory systems and limited sweat capacity.
What about exertional heat stroke? Who does that usually affect?
Typically, healthy young people, athletes, military personnel, and laborers. It's important to note that it can occur even without extremely high ambient temperatures. Risk factors include overmotivation, inadequate hydration, poor acclimatization, infections, and use of stimulants like amphetamines or MDMA.
Is the mortality rate different between the two types?
Yes, classic heat stroke has a high mortality rate, often over 50%, especially in the elderly. Exertional heat stroke has a lower mortality, less than 5%, largely because the affected population is healthier and treatment is often more rapid.
Let's talk about the pathophysiology. What triggers the systemic breakdown?
It starts when the body moves from a compensable state, where heat loss exceeds gain, into a non-compensable state. This leads to hyperthermia, cellular injury, and an intense systemic inflammatory response. Heat shock proteins and cytokines are released, resembling a septic shock-like syndrome.
And the GI tract plays a role too, right?
Absolutely. Splanchnic hypoperfusion causes intestinal ischemia and increased gut permeability. That allows endotoxins to enter circulation, worsening the inflammatory response and contributing to multi-organ failure.
How is heat stroke diagnosed in practice?
It's largely clinical. We look for the triad: core temperature over 40.5 degrees Celsius, neurologic dysfunction, and recent exposure to heat or exertion. Accompanying signs often include tachycardia, hypotension, and tachypnea.
Are there any red flags we might miss that delay diagnosis?
Yes, heat stroke is often mistaken for dehydration or heat exhaustion. Clinicians may not immediately recognize the inflammatory nature of the illness, which delays aggressive treatment and increases risk of complications.
Speaking of complications, what should providers be watching for?
Watch for DIC, ARDS, liver dysfunction, renal failure, rhabdomyolysis, and severe metabolic imbalances. These can evolve quickly and require ICU-level care.
Are any medications known to increase susceptibility to classic heat stroke?
Yes, drugs that impair thermoregulation like beta blockers, diuretics, anticholinergics, some antidepressants, and psychoactive medications can all raise the risk.
Thank you, Dr. Zhu. This has been a dense but crucial discussion. Final thoughts?
Recognize heat stroke early, treat it aggressively, and don't underestimate its lethality, even in the young and healthy. Preparedness saves lives.
Well said, and thank you to our listeners for joining us on Emergency Insights. Stay cool and stay safe.